Senate Health and Human Services Committee to order. It's Wednesday, April 2nd, 2025, and we do have a quorum present. We have quite a few bills on the agenda today, and we are beginning with Senator Klein, Senate File 2477. 2477 has already been heard in Commerce, and Senator Klein, you can go ahead and present your bill. I believe there is an amendment, but we'll get to that. If you want to talk about that as you talk about the bill, or if you have the Department of Health planning to talk about it. But Senator Klein.
Thank you, Chair and Committee. And this is from the Department of Commerce, one of their policy bills from the governor this year. I would ask if there's somebody in the room from the Department of Health and also from the Department of Commerce to come forward and help me present the bill.
And I see Department of Health. And who would like to, Ms. Timian?
Sure. Madam Chair, members of the committee, for the record, my name is Lieske Timian. I'm the Director of Government Relations for the Minnesota Department of Health.
And Senator Klein, do you want them to?
Yes, I'd like the Department of Commerce to present the bill.
Oh, okay. If you can state your name for the record and begin your testimony.
Chair. My name is Ashley Settlett. I'm the Health Policy Director in the Insurance Division at the Department of Commerce. We have two policy provisions in our policy bill this year. The first is related to the Medicare supplement open enrollment period that was passed during the 2023 legislature. It would add a 10% late enrollment penalty to individuals who decide to enroll during the open enrollment period rather than when they are first eligible upon entering Medicare at age 65. Our second bill modifies the state's guaranteed renewability laws and would allow health plans to terminate an individual health plan rather than pulling out of the market entirely.
Thank you. And Ms. Timian, can you talk about the Department of Health provisions?
Yes, absolutely. Thank you so much for the opportunity to be here, members. So Department of Health had some related commerce provisions that were amended in the Commerce Committee last week, including allowing insurers to provide the explanation of benefits documents electronically. This allows insurers to send explanations of benefits electronically, paper or both. If members prefer it, default would remain paper via mail. It also includes network adequacy, federal conformity, which would align our network adequacy standards with federal regulations, which is required for state-based healthcare exchanges by January 1st, 2026. Also includes some updates to the prescription drug price transparency technical fixes and enhancements, as well as a 340B technical fix, which just includes clarity and compliance amendments, including changes from an earlier version of this bill that was heard in the Senate to address concerns from generic manufacturers. We also have some updated regulation of health maintenance organizations to align with modern insurance practices and address regulatory gaps. And then we have other pieces in the A9 when we get to that. Thank
you. So we have the A9 amendment, and Ms. Timian, it looks like is it additional Department of Health provisions that you want to speak to? And then we can talk about that.
Sure. Yes, so some of the first parts of the E9 address some technical corrections suggested by Senate Council around the HMO language. We also added in our policy bill that only needs to be heard by the HHS committee about updating the standards for hospital closure and curtailment of services notifications. This really just clarifies this procedure for both the hospitals and specifies that if inpatient health services are moved to another hospital or campus, or if maternity and newborn care services are discontinued, advance notice is required. This adds clarity both for the provider networks as well as the impacted communities. The amendment, I believe, also will add clarity around who is eligible to be on the agency's Health Equity Advisory and Leadership Council, which strikes confusing and unnecessary sentence in that as well. Thank you.
Thank you. Members, the amendment came about partly because the department has been waiting for, or we've been waiting for jackets for these bills for many, many, many weeks and months, and they just showed up this week. So we're trying to get provisions included from those bill jackets, so that the way this is coming forward is maybe not the way we would hoped, but that's the reason. Members, do you have any questions about, well, let's first just address the A9 amendment. Members, do you have questions about the A9 amendment?
Madam Chair.
Senator Klein?
Also included in the A9, you may recall, Madam Chair, when we heard this in Commerce, there's an expansion within this bill of the drug transparency reporting language where generics were going to be included in the price increase reporting language. After some concerns from the industry within the A9, we're removing that requirement. So reverting back to existing statute on drug transparency reporting.
Okay, thank you. That's helpful to know. That was something we discussed in Commerce. Any other questions or comments? Senator Klein, do you want us to refer or pass the bill back to your committee, or is it something we could just lay over?
Madam Chair, a vote to pass back to Commerce would be optimal. Okay.
So first, members, I'd like to take a vote on the A9 amendment. Members, all those in favor, or Senator Mann moves the A9 amendment. All those in favor, please signify by saying aye. Aye. Any opposed? The A9 amendment is adopted. And now, members, do you have any further discussion or questions about the bill? Senator Utke.
Thank you, Madam Chair. And question is around the penalty related to Medicare supplements and the timing on it. What have we been experiencing? Is there a lot of people that are not abiding by the fact that we have an open window for enrollment, and they're trying to, shortchange the policy or amount of money they're paying maybe? What are you seeing on that?
And just before I go to you, Senator Klein, that is a particular area that is not in our jurisdiction. I will let you can answer the question, but I would want to keep us focused on the things that are in the HHS jurisdiction, since it already had the Commerce hearing. But Senator Klein.
Sure. So the article that Senator Utke is questioning about is Medicare supplemental insurance plans, which people currently purchase if they want additional health insurance above and beyond what Medicare provides. 2 years ago, we passed legislation that would sort of remove analysis of pre-existing conditions from purchase of Medicare supplement plans, and also create an open enrollment. There was concern from constituents, frankly, that this would increase rates significantly and sort of destabilize that supplemental product. So last year we delayed implementation of that for 2 years. So currently the changes that we effected 2 years ago have not gone into effect yet. This is sort of anticipatory language, knowing that those changes will go into effect in 2026, and trying to create some barriers around open enrollment to sort of keep the market prices more stable. Hopefully that answers your question.
Senator Utke.
Thank you, Madam Chair. That's what I was wondering what was taking place, so thank you for that.
Any other questions? Oh, Senator Abler.
Well, thanks. I'm sorry I was late. So welcome, Senator Klein. I'm glad you're bringing up this topic of, actually, you can keep the, whatever. So I'm glad you're working on federal things too. That's good. I just wanted to fit that into the conversation. But my serious question is on this curtailing operations of hospitals. I just want to remind you that even for the improvements here, it's still a lame review. So Alina decided to close overnight pediatric beds, and Mercy, we had a meeting, and they even took comments until noon the next day. And then they just did it without any plan. And so my desire was the Department of Health would weigh in and actually say it's okay, But at the very least, as this goes forward, at least they should offer an opinion. Because more and more consolidations are happening, and wherever we're going to be a part of the discussion, it's not going well, especially for greater Minnesota. And we're kind of good here, but they close those beds without any consideration for could those services be elsewhere. And they said, well, there's only 2 beds. Well, there's actually many, but they were full of people who were boarding there. And so if you have a pediatric urgent thing, we had testimony at the hearing that we did have where this family came forward and they said if they didn't have those beds, their kid would be dead because there wasn't time to get all the way to Children's. But by the way, there's not an agreement with this particular provider to go to Children's or anywhere else. And so just to encourage you along the way, I was this close, I thought, to getting something done last year ahead of the closure. But at this point, it's just driven by, by a corporate policy about what they want to do. And so I know that's on your mind. So anyway, thank you for that. Thanks for the chance to bring it up. And you can comment if you want.
Senator Klein or Ms. Timian? No.
Yeah. Madam Chair, members of the committee, we would be happy to continue working with you, Senator Abler, on other ideas to update this language. This was really in response to adding some clarity, but always happy to work with you.
So, Madam Chair, just notice here
Senator
I want to
Abler.
give the Department of Health more power. So, I mean, mark your calendar. Thank you.
Let's see, I had Senator Lieske. Did you have? Okay. So members, I don't see any other questions or comments. Any other comments, Senator Klein? So the motion will be Senator Mann moves that Senate File 2477 as amended be recommended to pass and be referred to the Committee on Commerce and Consumer Protection. Members, all those in favor, please signify by saying aye. Aye. Any opposed? The motion does prevail, and Senate File 2477 as amended is referred to the Committee on Commerce. Thank you. And now we will move to House File 1346. Senator Draheim.
Thank you, Chair Wickland and members. We have House File 1346 in front of us, which passed through the House 134-0. So with that, I know we're short on time. I appreciate your hearing the bill. Go to Lisa, the testifier.
Good morning. Welcome to the committee. And if you can please state your name for the record and begin your testimony.
Madam Chair, members of the committee, I'm Lisa Hollensteiner, retired emergency department physician, was a previous member of the Governor's Task Force on Child Protection. I'm the board chair of Safe Passage for Children, which advocates for children who are at risk of maltreatment, and also the leader of the coalition, which is a group of 30-plus frontline professionals who deal directly with child abuse, including law enforcement, mental health, child abuse pediatricians. Child abuse is a significant but overlooked issue in Minnesota. We see this in state data, but it is rarely discussed. Each year, about 5,000 children are confirmed victims of abuse. Last night in the Rotunda, we honored 28 children who were killed in Minnesota last year due to abuse. The number killed each year often mirrors the number of children dying of cancer in Minnesota each year. If this were a childhood disease, we would be pouring money into treatments and cures. Like a disease, we know that prevention is key, and there are better outcomes for kids when abuse and neglect are detected and mitigated early on. This is where mandated reporters come in. Mandated reporters play a critical role. Teachers, child care workers, healthcare workers, law enforcement, social service professionals are often a child's first line of defense. Nearly 80,000 reports of potential maltreatment were made across Minnesota counties in 2022, and 80% originated from mandated reporters. Robust training for mandated reporters is essential. However, after reviewing the state's mandated reporter training last year, we were shocked by what was and what wasn't taught. Of the 45 minutes in training, only 2 to 3 minutes was dedicated to recognizing signs of abuse. Additionally, the training misrepresented child protection as potentially harmful to families and included guidance that contradicted state law, such as requiring reporters to be certain of maltreatment rather than having reason to believe. We've met with the Child Welfare Training Academy and DCYF, and they have agreed to revise their training. In planning this training, we strongly support this bill, which ensures training meets 2 basic requirements: Number one, at least half the training must focus on recognizing signs of maltreatment. For example, daycare workers may not realize that any bruises on infants under 4 months old are suspicious. A preschool teacher might not know that bruises on the neck are rare and concerning. And a school secretary seeing a child regularly arrive hungry may not know if it's poverty or statutory neglect. A few minutes of training on recognizing signs of abuse is not enough. Signs of maltreatment must be incorporated into mandated reported training, not treated as an afterthought. Secondly, training must be informed by professionals with expertise in child maltreatment. A child abuse pediatrician is best suited to educate on physical signs of abuse. An attorney ensures legal accuracy. A mental health professional can advise on sensitive questioning. A social worker can provide insight on available resources. This is a simple, common sense bill that can have a profound impact on protecting Minnesota's children. I urge your support to ensure mandated reporters receive comprehensive, expert-informed training to help keep children safe. Thank you for your time and consideration, and I'm open to any questions you may have. Thank you.
Thank you very much for your testimony. Members, do you have any questions or comments about the bill? Senator Abler.
Well, thanks. Looks like it's a good idea. Can you just comment? And I forgot your name, but what is the standard? Is it certain or reason to believe?
Madam Chair and
Ms. Holstein.
Madam Chair and Senator Abler, it's reason to believe.
All right.
Senator Abler.
I just wanted to be sure. So we've had quite a bit of discussion about this. I'm not going to drag it out there, but this is a good step. Thank you.
Thank you. Any other member questions or comments?
Madam Chair, I'll move the bill if you want.
Oh, thank you. Yeah, I don't know, any final comments, Senator Draheim?
Just appreciate the time. I think this is a simple step in the right direction, so appreciate the support.
Thank you. Yeah, it seems like a very good step. If the training can be focused and clarified, it sounds like we have a lot of the information we need to make sure that the training is more effective and more focused. And so I'm glad to see that this will be moving forward to help, make sure that that happens and make sure that enough of the time is spent on really critical aspects of looking for signs of child maltreatment. So thank you again for your testimony. And Senator Abler moves that House File 1346 is recommended to pass and be placed on general orders. Members, all those in favor, please signify by saying aye. Aye. Any opposed? The motion does prevail, and House File 1346 is passed and placed and sent to general orders. Thank you. And next we have Senator Utke with another House File 129. Senator Utke.
Good morning, Madam Chair and members. This morning I do have House File 129. This bill requires the Director of Child Sex Trafficking Prevention to submit a program evaluation to the Legislature. This statute falls under the Sexual Assault Victim Statute, and the program evaluation that is our topic of discussion today involves safe harbor for sexually exploited youth in statute. The Director of Child Sex Trafficking Prevention is responsible for the development and providing comprehensive training on sexual exploitation of youth for social service professionals, medical professionals, public health workers, and criminal justice professionals. The Director is responsible for collecting, organizing, maintaining, and disseminating information, monitoring and applying for federal grants, managing the grant programs and the requests for proposals for grants, identifying best practices and conducting a comprehensive evaluation of the statewide program for safe harbor of sexually exploited youth. Youth 24 years of age or younger are eligible for all the services and supports. And back to the bill language, this bill adds that the Director must submit the updated evaluation to the chairs and ranking minority members in the Senate and House of Representatives. committees with jurisdiction over health and public safety in each odd-numbered year. Currently, the director only had to submit the evaluation to the Commissioner of Health. So that's all this bill does, is it just expands who receives this report. So that's all I've got.
Thank you. And I don't have any testifiers signed up. Members, do you have questions or comments about the bill? No? Seeing none, any final comments? I mean, it seems like a reasonable request that we have a more standardized timeline for, and then that we in the legislature are able to see the report.
That's right. It's a very simple bill, but it's very straightforward on what the instructions would be going forward. So thank you, Madam Chair.
Senator Utke moves that House File 129 be recommended to pass and be placed on general orders. Members, all those in favor, please signify by saying aye.
Aye.
Any opposed? The motion does prevail, and House File 129 is passed and will be sent to general orders. Next, Senator Utke, you have Senate File 2743.
Thank you, Madam Chair. This bill will extend audio-only telehealth services to those covered by medical assistance for 3 additional years upon federal approval. Existing law requires medical assistance to cover medically necessary services in consultations delivered by a healthcare provider through telehealth in the same manner as if the services were delivered through an in-person contact. These telehealth services must be paid at the full allowable rate for the same in-person services. However, audio-only communications between the healthcare provider and the patient is currently only covered until July 1 of 2025. Senate File 2743 temporarily extends medical assistance coverages for audio-only communications between a healthcare provider and the patient from the current July 1, 2025 sunset date until July 1 of 2028. And with that, Madam Chair, I have Sue Abderholden joining us this morning to testify further on this bill.
Thank you. Welcome to the committee, Ms. Abderholden. Please state your name for the record and begin.
Thank you, Madam Chair. Members, Sue Abderholden, Executive Director of NAMI Minnesota, and we strongly support this bill providing audio-only telehealth. People with mental illnesses actually use this mode probably the most. We actually did kind of a non-scientific survey last year. We had about 176 people respond, and we asked them to rate their experience with audio only on a scale of 0 to 10. And 82% rated their experience 6 and above. And so people clearly find it very useful. Especially in rural areas, they don't have to travel somewhere, which is actually helpful in the winter. Not everyone actually has a smartphone or internet. Sometimes, people with mental illness, because of their symptoms, can forget that an appointment is there, that when they got a phone call, they could immediately connect with someone. Also provide a lot of flexibility in their scheduling. It helped if you had agoraphobia and made it difficult to leave your house in the first place. One thing I want to stress, and it's why I'm kind of surprised, frankly, at the fiscal note, is the service being provided is actually therapy. It's the mode. And so people are still going to access therapy somehow, but now they might just miss more appointments. One of the things that we found is if you miss like 3 appointments in a clinic, then you can't go there anymore. And so we found that people weren't missing as many appointments because they could connect by phone. So I think it's just an important distinction. We're not paying for an additional type of treatment. We're actually paying for a mode to deliver therapy to people. And what we found is that, if people can stay connected to their therapists, we see fewer mental health crises. So I think it's a very important bill, and I hope that you support it.
Thank you. Members, do you have questions or comments about the bill? Senator Abler.
Well, thanks. Just a comment to the whole idea. Following this idea for a long time and support the bill. It's a good idea. But at some point, we should discuss if the full fee is warranted or not. if you're working in a hospital or a clinic, you got to pay for all the hardware and everything and staff. And there's a situation where I imagine someone could do a lot of this telehealth from their home and not incur those costs. And if we're trying to ever get our arms around what things cost, I think that's something to consider. I know the clinicians, they want all the money they can get, and I don't blame them, especially at some of the rates that get reimbursed. But it's just a thought going forward that if you want to do more of this, and some clinicians that talk about burnout, maybe they just would really like to be in their home and kind of be doing a consulting practice. So just a thought, and I don't have an amendment. I'm not promoting it, just offering the thought. So thank you.
Other members? Senator Mann.
Thank you, Madam Chair. I do have an amendment.
Senator Mann moves the A1 amendment, and members, that was passed out. Senator Mann.
So, thank you, Madam Chair. The A1 would also extend the same sunset to commercial plans. And I talked to Senator Utke yesterday about it. That's really it. We want parity between all the plans. And again, not trying to offer a new service, just the delivery of the service.
Senator Utke, do you have any thoughts on the amendment?
Thank you, Madam Chair. And yes, Senator Mann did give me a heads up on this, and reading the amendment last night, it seems like it's not expanding anything, it's just helping connect people to their provider in the case of scheduled appointments, et cetera. So it's a friendly amendment.
Any other member discussion about the A1 amendment? Well, seeing no other discussion, and per Senator Utke's response, members, all those in favor of the A1 amendment, please signify by saying aye. Aye. Any opposed? The A1 amendment is adopted. Any other further discussion about the bill? Seeing none, I do think it's an important mode that should be available to people. I would hate to see it just become unavailable, and I do think it would have a negative impact on people. We want to see people able to access services in a convenient way, and we've seen that this reduces barriers. Thank you, Senator Utke, for bringing the bill forward. Do you have any final comments?
Nope, I think we've covered it. Thank you, Madam Chair. And, it's all about hopefully just keeping people in contact with their care and succeeding with whatever challenges they have. So thank you.
And with that, Senate File 2743 as amended will be laid over for possible inclusion. Senator Utke, you have Senate File 1497.
Thank you, Madam Chair. Members, Senate File 1497 requires medical assistance and MinnesotaCare to cover long-term ambulatory electrocardiogram monitoring services. These devices are external cardiac monitoring patches that patients wear for 48 hours or longer. The coverage required by this bill includes the provision of such devices as well as the interpretation of the data gathered by them to detect heart arrhythmias that can lead to stroke, cardiac arrest, or other comorbidities or medical complications. The reimbursement rate for such services must be at least 100% of the Medicare physician's fee schedule rate or higher. The new rates would be effective January 1, 2026, or upon federal approval. And Madam Chair, I believe we have joining us as a testifier via Zoom, Elizabeth Stoll.
Thank you. Yes, Ms. Stoll, if you can state your name for the record and begin your testimony.
Thank you, Madam Chair. I'm Elizabeth Stoll, and I work with Baxter Healthcare, which makes one of the long-term ambulatory electrocardiograms. And ours is called a Barty patch, and it basically is it's like a pen, and you stick it onto your chest. and you wear it like that. You can bathe with it, you can, change clothes, you can do pretty much work out, anything that you need to do with the Barty patch on, and it lasts anywhere from 48 hours to 15 days. So it's kind of in the middle of the time for these types of devices, ECGs. There's a traditional Holter monitor, which is only worn for 48 hours, up to 48 hours, and you've probably all seen them with the patches and the cords and the box that the cords plug into, and so it's a little more cumbersome to wear. You can't bathe with it on. You can't do certain things, and like for children, it's very difficult to keep the leads on and things like that. But it is a great product for just short-term monitoring. But there is a need to have longer-term monitoring done for people that have arrhythmias, because sometimes they're missed within that 48-hour period. Maybe the person only has an arrhythmia every 7 days or every couple of weeks. And so there is some really a need in Medicaid to have this middle product for the 2 to 15 days. It will lessen cost to Medicaid if raised the rates, because when the manufacturers come into the marketplace to supply Medicaid, it will allow for these products to be there that will catch various different arrhythmias that were not caught with the Holter monitor. They also offer a mail-in solution, which allows for patients that live in rural or don't have transportation, they don't have to use Medicaid non-emergency transportation, to mail in their patch. They don't have to deliver it back to the doctor like you would with a Holter monitor. And so there's lots of different advantages and financial advantages to the state for raising the reimbursement rate to 100% of Medicare rate. And I'm here to answer any questions. Thank you.
Thank you. And I have another testifier listed, Jessica Coughlin. If you could state your name for the record.
Madam Chair, I believe that was Jessica you had on the other name? Okay, I believe both Jessica and Andrea are here just for questions if we need them.
Great. Members, do you have any questions about the bill? And don't see any. I think your handout does a good job. It helps me understand better kind of where they are, where you're perceiving that savings would come in and what the reasons are for that. Any further comments, Senator Utke?
Thank you, Madam Chair, for hearing the bill. And like a lot of things we have heard, there are things that we bring forward that hopefully have savings in the future. And this happens to be one of those too, where number one, it's better for the patient. They can this extended time, but in the end, it should be a money saver, so it's a win-win for everybody. So I appreciate you hearing the bill.
Thank you. I'm not seeing any other member comments. Senate File 1497 is laid over for possible inclusion. Thank you. And next, we'll move to Senate File 595, Senator Lieske. Senator Lieske.
Thank you, Madam Chair and fellow HHS committee members. I'm here to present Senate File 595 in relations to modifying the MA coverage of chiropractic services. I would first like to thank my co-authors, Senator Utke, Senator Hoffman, Senator Barr, and Senator Kupek, as this is a very important issue for my patients, including and all other patients on MA for chiropractic services. The bill is not very long, as you can see. It's a very short bill. The main points that I would like to cover is that it removes the annual evaluation limitation, adds 3 qualifying diagnoses for treatment, and adds 2 treatments. I'm going to circle back to the annual evaluation limitation. The purpose of removing that is actually because many times patients come into the office for acute purposes. They've fallen, they've hurt their back, they slipped on the ice, something of that nature. A lot of times you need to re-examine for a new injury, and if you only can examine once per year, it's not a covered service, and so now you're evaluating a patient and it's not covered. So most providers, it makes it pretty difficult to evaluate a patient for a new injury, and that's the purpose of that. As for the qualifying diagnoses, as you can see, acute spinal pain, chronic spinal pain, and neuromusculoskeletal pain, all within our normal scope of practice. So it's not an expansion of practice, it's not an expansion of scope, that's what we already work with every day. So, and then finally, the two treatments, the therapeutic exercise and the manual therapy techniques. These are services that are already provided through other healthcare providers, including occupational therapists, physical therapists, and other professions like those. So at the end of the day, it's not actual expansion of services that would be provided by MA. It would just add a list of another person of providership that could add to those services. And so with that, I have a testifier who I will have speak to it even more.
Welcome to the committee, and please state your name for the record and begin your testimony.
Thank you, Madam Chair and committee members. Good morning. My name is Richard Printon. I'm a practicing doctor of chiropractic, and for the past 25 years, I've been employed by Hennepin Healthcare. Today, I'll speak in support of Senate Bill 595 relating to modifying chiropractic coverage services in the medical assistance and the MinnesotaCare programs. Most of my work for Hennepin Healthcare is treating patients. I do this at our clinic and specialty center in downtown Minneapolis. Secondarily, I serve as Division Director for Integrative Health. Our division consists of 7 chiropractors, 9 acupuncturists, and 5 physical therapists. At Hennepin Healthcare, our MHCP and MA patient base for chiropractic and acupuncture care is about 25%. As part of the neuroscience group at Hennepin, chiropractors are an integral part of the care team. We receive most of our patient referrals from our medical providers. In addition to my work at Hennepin Healthcare, I also serve on the Health Services Advisory Council, or the HSAC committee. In 2023, DHS asked our HSAC committee to study and discuss the expansion of chiropractic services within the Minnesota healthcare programs. DHS asked our committee to review the current research with regards to chiropractic treatment, hear testimony, and ensure they are providing the most appropriate covered services for chiropractic care. On October 11th, 2023, the HSAC committee voted almost unanimously to pass the recommendations outlined in SF 595. In the current MHCP policy, only 1 chiropractic examination per year is covered. This becomes problematic, for example, if an MA or MHCP plan patient presents in January with neck pain and was successfully treated and released, but returned in July with lower back pain complaints, the patient is presented with an advance receipt notice of non-covered service. And this is that form, it's the bane of our existence. So the patient needs to agree to pay for the examination or leave without being seen on that day. Most patients cannot afford the examination and leave. The patients are sitting right in front of us, and I need to talk about cost of care and have them sign a form rather than treat this patient for their back pain. Many of these patients speak English as a second language or are of lower literacy and may not fully understand the form, and they leave very frustrated and confused. If patients are unable to sign the advance receipt notice of non-covered service, I recommend that they go back to their primary provider and ask for a physical therapy referral, but all this takes time, maybe a month or so, to see both of those providers and get schedules set up. The other option patients use is very costly urgent care or emergency room care visits for simple spinal pain conditions that chiropractors treat. In the current MHCP policy, spinal manipulation and acupuncture are covered services. Therapeutic exercises and manual or soft tissue therapy are not. If we perform soft tissue manual therapy or self-care exercise instruction, which all chiropractors do, we again have to have the patient sign the advance receipt notice of non-covered service. The therapies are used by chiropractors to assist in recovery from pain. Having patients participate in their own care by promoting exercise and self-care is a very important part of understanding and recovering from back pain. Instead of having chiropractors treat MA and MHCP patients with self-care exercises and manual therapy, the patient must delay this care and be referred for physical therapy for this service that chiropractors are well trained for. Thank you very much, and I urge you to support Senate Bill 595 and would answer any questions.
Thank you. Members, do you have questions or comments about the bill? Senator Kupek.
There's the microphone. Thank you, Madam Chair. So Senator Lieske, obviously, you and I have talked about this bill. I'm on here as a co-author. So the governor's budget, though, if I'm remembering correctly, kind of zeroes out reimbursements to chiropractors. Is that correct?
Senator Lieske?
Thank you, Madam Chair. Senator Kupek, yes, from what I understand from the governor's proposal, it's going to zero out coverage for anyone over the age of 21. And so reading through the fiscal note of that is it would save roughly $7.5 million in the first biennium. And I think the numbers based on what I've got in front of me is about $11 million in the second biennium.
Senator Kupek?
Okay, thank you, Madam Chair. And Senator Lieske, then how does that differs, though, I believe, from the fiscal note that we have from this bill? So something maybe doesn't, because this, if I'm correct, this will kind of keep it in, the reimbursements, but the fiscal note we have here does not quite match with what the governor is planning on savings.
Senator Lieske?
Thank you, Madam Chair. Madam Chair, I guess I don't know how to answer that entirely. Like I said, I've got two fiscal notes in front of me. I've got ours for this bill. It's $8.5 million for the first biennium and 13.6 for the second. Still not sure how they got their numbers in comparison. From my understanding, maybe somebody from DHS could answer, or.
Someone from DHS is approaching. Welcome to the committee, and if you can state your name for the record and proceed.
Morning, Madam Chair, members. Giogo Hayes, Division Director with the Department of Human Services. Are you guys trying to understand the fiscal estimate for both provisions?
I think primarily we want to understand, or the question is understanding the fiscal note that was provided for Senate File 595.
Sure.
Mr. Reyes.
Madam Chair and members, so this fiscal note, as was described by Dr. Printon, looks at expanding services for chiropractic services. So what we did, as was articulated, some of these services are covered by PTs and OTs. So we went into the data, quantified the number of visits that PTs and OTs do for similarly situated services. We took an average payment for those particular services and then estimated a potential uptick in some people getting those services from chiropractors, and then multiplied those numbers together to get the total in the fiscal note here.
Senator Kupek, does that answer your question?
Well, sort of. Thank you, Madam Chair. So question then, do physical therapists get the same reimbursement rate as chiropractors? Because I think they get more. And so if a patient was then to choose the chiropractor over the physical therapist, then that would actually be a lower reimbursement rate for the programs, if I'm thinking correctly. Does that save money? Maybe? I don't know.
Mr. Reyes.
Madam Chair and Senator, the bill assumes that some additional folks will get services they're not getting today, so that if you present at a chiropractor who is doing services, they'll do some additional services that they haven't done in the past. One example, as Dr. Printon also mentioned, and Senator Lieske mentioned, this bill allows for additional evaluation and management. So we know that members are showing up in chiropractor offices today. They're getting one evaluation and management in the example that one of the testifiers gave earlier, and then coming in later for a second episode of care where that evaluation and management is not getting billed today and is being billed to the member. And so the change in the bill would require that we pay for that E&M visit, and so that would be an additional cost to the program.
Senator Kupek.
Thanks, Madam Chair. I guess, I know my wife is going through a round of physical therapy right now, not from a chiropractor, from a physical therapist, and it is, the price on it's through the roof. Our insurance is covering almost none of it. So I'm just, trying to see if there is, even if you're expanding care, if there is possibly a cheaper way that maybe the chiropractor service is a slightly cheaper way to go. So that's all. Thank you, Madam Chair.
Thank you. So I just had one question about so if someone comes in for one and has one annual evaluation, and then they need to come back, like you mentioned, for a different issue, if they pay out of pocket for that annual evaluation, then are treatments that are related to that covered that go beyond that? Senator Lieske?
Thank you, Madam Chair. Yes, in my experience, as long as the exam is paid for, then the treatment of the new ongoing actual treatments are covered. It's very similar to Medicare, unfortunately. Medicare on a national level does not pay chiropractors for the exam, but they expect us to do it. So we have to bill the patient for the exam and then provide the treatment, which is then covered. So it's very confusing, and I'm still not sure why or when that was created, or how it got created that way. As Senator Mann's definitely given me a look of confusion, because how do you provide treatment to a patient without doing an exam and understanding why they're there? And so that's something that I would like to see changed especially from the state perspective, because the Medicaid level is very much following Medicare, other than that it does allow for one exam.
Members, Senator Abler.
Thank you, Madam Chair. If Mr. Reese can come back, please, about the fiscal note.
Yes, he can. Senator Abler.
Well, thank you, Madam Chair and Mr. Reese. There's two fiscal notes. One is from the governor's proposal, and then this one here. And so can you explain to me on the governor's proposal, and it's a similar question to this one. So when you just take away the ability of a person, low income, perhaps person with a disability, to get chiropractic care if they're over age 21, and save money by taking that care away, as I read in the fiscal note, the assumption was that none of those people would go anywhere else. Can you explain how that interaction is not a meaningful one?
Mr. Reese.
Madam Chair and Senator Abler, apologies. Unfortunately, I can't. I wasn't involved in that exact fiscal note, so I don't know what the offsetting impacts were. But it sounds like based on your description, there weren't any in that particular fiscal note.
Well,
Senator Abler.
Well, okay, well then, I don't know who wrote that one, but in the same situation here. So Madam Chair, I don't know how many patients were involved in there, some thousands of people worth $7.8 million a year. So I don't know what that would amount to, 10,000 or something. But the assumption is those people would go nowhere else. And they would certainly go to a PT or orthopedist or the ER or something. And so in this fiscal note business that we do, and I'm not being critical of you, Mr. Reese, I'm just in wonderment how that we can look at these things in a vacuum. And Mr. Reese, if you were part of this fiscal note, by providing a little more services, I'll suggest to you, and maybe the word inform you, is that people then would not use the therapist to get the same service they just got yesterday from the chiropractor. And just to tell you that. And so actually studies show that when people go to chiropractors more, the total cost of care is less. There's a great deal of data, I'm not going to go on at length, but there's a great deal of data that when they appear to one of us, we do less scans, we do less imaging, we get paid less anyway, which kind of sucks, for the same thing, which is actually violates state law. But the total cost of care, the package of care is less. And so we forever chase around about this matter. In the fiscal note that you wrote or you were part of for this particular bill, do you have any reduction in there for other costs due to people choosing the chiropractor and not utilizing the other services that they would have otherwise gone to?
Mr. Reese.
Madam Chair and Senator Abler, I'd have to double check, but I would just reiterate real briefly that the expansion of this particular bill, as recommended by HSAC, and does have multiple pieces to it, right? So there's the therapeutic exercise, there's expansion of manual manipulation, and there's the payment for the E&M visits, right? So there's multiple things going on. And so if you're interested, I can certainly go back and see if I can look in the data to see what the cost is relative to each of those component parts. But my suspicion, as I recall, this was done a little while ago because it was a bill from last year too, is that the majority of the cost is related to the E&M, which is not paid for today and would be in a new cost to the program. But I take your point.
Madam Chair. Mr.
Senator
Reese.
Abler.
So let me just be more clear. It does not allow for any reduction of other services. substitutionary effect, which is absolutely going to happen. If the chiropractor is able to offer a bit more comprehensive care, they're not going to go down the road to the therapist because they already have the treatment that they need. And so I'm going to urge you in your analysis to consider the direct substitutionary cost, savings of that. And otherwise, we are failing to take advantage of a bona fide savings in an industry which is crushed for money in a committee. This bill, the way it's written, would be a savings to the industry if you consider any of the most rudimentary research data. So if you can take that back to your workshop, that would be good. And just one more comment. So I mentioned Alina from time to time. Why does Alina not use more chiropractors? You know why, Madam Chair? Ironically, they can't make any money at it because the rates are so low and the service is so narrow that they have to rely on other providers in their networks, which is an error. And if we're doing the best, and these are, Madam Chair, these aren't wealthy people. These are people at Medicaid and MinnesotaCare levels of income, very nominal income, and they're being denied the opportunity to get actually a superior treatment in many cases, not arguing PT versus chiro, but you want to have a choice. So I think that's, even as an ethical thing, you know, the governor's office says, oh, it's just a way to save some money. Okay, I see an ethical conflict in that, to deprive people that are above 21 who are working a marginal job that are barely making it, that are, so anyway, so thank you for the attention. This is the kind of thing we need to spend more time doing. What really works better, what's more, valuable, and giving people the full choice. That's been the thing all along. So thank you, Madam Chair. Appreciate the opportunity.
Any other member comments or questions? Senator Mann.
Thank you, Madam Chair. I almost thought that I heard someone say that for-profit healthcare was a bad idea. And I thought I heard that, but I just wanted to say it out loud that for-profit healthcare is a bad idea. So thank you.
Any other member comments or questions? Senator Lieske, any final comments?
Thank you, Madam Chair. I want to say thank you again for giving me this opportunity to present why I think this is so important and representing my patients. The one thing that I try to stress to everyone is that Medicaid and MinnesotaCare patients are, as Senator Abler referenced, less able to afford health care. And so by taking away providers that they have likely been attending or going to for years, decades, however you want to describe it, my personal patients, I have a few that are very reliant on this care. And so by taking it away and then not allowing it to expand to the point where they can afford it even more is concerning. And so I'm here to fight for those patients and for the patients across the state of Minnesota.
Thank you. Thank you for bringing the bill forward, and I feel like we've learned a lot more just through having this discussion. Senate File 595 will be laid over for possible inclusion. Next, we have Senate File 2037, Senator Boldon. Senator Boldon.
Thank you, Madam Chair and members. I'm grateful to be before you with Senate File 2037, which would appropriate resources to the Rare Disease Advisory Council. I'll be brief as I want to turn to my testifiers, but the Rare Disease Advisory Council represents rare disease patient communities that, while individually rare, collectively are not actually rare. About 10% of people in the general population are impacted by a rare disease. And so the work of this council really is critical for these families and for these very rare diseases. It is true that patients with rare diseases have poor health outcomes. It often takes an average of 7 to 8 years to get a diagnosis. And there's a lot of time and cost and energy and stress that comes over that 7 or 8 years. On average, patients receive 2 or 3 misdiagnoses along that path in order to getting to the accurate and correct
diagnosis, and only about 5% of the roughly 10,000 rare disease communities have an FDA-approved treatment. So the work of the Rare Disease Advisory Council really is critical and supportive of these families for about the 10% of folks who have a rare disease. And with that, Madam Chair, would turn it over to testimony.
Welcome to the committee, and please state your name for the record and begin your testimony.
Thank you. Thank you, Chair Wickland and members of the committee. My name is Erica Barnes, and I'm here to testify in support of Senate File 2037, and I'm the Executive Director of the Council. The Minnesota Rare Disease Advisory Council is grateful for the funding from last session that allowed us to operate on the budget that we identified at our establishment as necessary to execute on our work. With that funding, we've been able to convene the rare disease community, connecting patient groups to researchers interested in their rare diseases that otherwise did not know each other, develop policies such as our presumptive eligibility bill that will both expedite processes to improve care as well as reduce healthcare costs, launch a task force to identify sustainable reimbursement pathways for gene therapies, and initiate a telementoring program to close the knowledge gap between our specialists, primarily in urban academic medicine, and general care clinicians unfamiliar with rare diseases. The urgency for the state of Minnesota to continue to prioritize this work has intensified even in the last week. All of the restructuring and layoffs at the federal level has led to uncertainty as to whether the critical public infrastructure that so long has facilitated rare disease advancement will exist at the federal level. Grants to clinicians who are eminent in the field of research for rare diseases are going unreviewed. The status of the NIH-funded Rare Disease Clinical Trial Readiness Consortia, whose patient committee I actually co-chair, is in limbo. And perhaps most concerning of all, the Advisory Committee on Heritable Disorders in Newborns and Children, a division of HHS that oversees the addition of diseases to the federal recommended newborn screening panel, has been paused. You all heard Shanna and Nick Quimby 2 weeks ago tell their moving story of losing their son Gavin to a devastating rare disease, a disease that is now detectable by newborn screening and highly treatable by a newly FDA-approved gene therapy. That disease was scheduled for review and possible addition to the panel in February. That meeting was canceled. When the meeting was canceled, the community hoped for a hearing in May. I learned yesterday that that meeting has also been canceled with no communication on if and when the committee is going to continue to meet at the federal level. The current reality for rare diseases is that if the work is to be done, it's going to have to be done at the state level. RDAC's founding statute directs us to engage with the Newborn Screening Committee, as well as other state agencies, and this state-level work could not be more crucial. We must continue to identify children through newborn screening. We must continue to advance the field of gene therapy, and we must invest in public research that undergirds medical advancement for all and alleviates untold human suffering. So I urge you to pass this bill so that the hard-fought advances we've made for rare diseases in the state and nationally is not lost, and we can continue to do our work. Thank you.
Thank you. Members, do you have questions or comments about the bill? Senator Abler.
Well, thank you. And I was goofing off eating a muffin provided by the Department of Health today, so I didn't catch your name to the testifier, but thanks for that. Bring more snacks, by the way. That's always a nice thing. But this, I'm just trying to be a little levitous in this. I'm just really sad. Can you explain the pause on the federal side, please?
Yes.
Ms. Barnes? I'm sorry.
Chair Wickland, Senator Abler, sorry, I too am very sobered by the pause. I'm sorry, I'm going to get my acronyms. So the division of HHS that oversees additions to the recommended newborn screening panel is being restructured and reorganized. However, the community has not been given clarity about what an approval process would be at the federal level for adding diseases to the newborn screening panel. The community is really scrambling to figure out what's going to happen. I've been asked to go to Washington to try to also find out what might be happening, just to simply get clarity on if there will be a recommended newborn screening panel and what that would look like in the future, but it's indefinitely paused.
Senator Abler.
So thank you, Madam Chair. So it's not part of the latest CDC thing that happened. That's a different matter. Is that right?
Ms. Barnes?
Chair Wickland, Senator Abler, it's not part of the CDC that I haven't gotten
$250 million reduction that they just did 10 minutes. Okay.
Chair Wickland, Senator Abler, I know the CDC defunding did affect the rare disease community. Frankly, I haven't had a chance. I've been testifying all morning, and I just heard through the grapevine that happened. I haven't gotten a chance to really dig into that. But I know it has affected the rare disease community drastically.
Thank you.
Senator Abler.
And so we just talked about, so I mean, just on a bigger picture, the families that find themselves in these circumstances had no idea that they were going to spend their lifetime understanding and learning all kinds of new words and acronyms and doctors and what. So I think we've really been good leaders on this, and Senator Miller and others, and Senator Boldon and whoever else that had a piece of this. So it's really something, I think in the topics as we look to the budget, I think some of these things are just really essential. And as we respect life and the opportunity for people to be all they can be, I think this is something really core that I think everybody would go like, we better do that. So Madam Chair, I didn't publicize it, but I did write a letter to the CDC last week and copied the departments, and if you want those, you can ask them. It's not, I mean, it's a public letter to the CDC. They haven't written back yet, but I called their actions canceling money on Tuesday for Monday morally indefensible. You just can't do that. And there's 170 employees, I guess, at MDH that are going to be doing something else now, and I'm so sorry for that. And I really appreciated Ms. Underwood's commentary about how thoughtful they were going forward with this one-time money. I don't always know the answer to all the questions I ask, and I didn't know how thoughtfully they had anticipated the soft landing of those programs. And I know Wellness in the Woods, which is not this committee, had 35,000 calls a year with 20 staff on their warm line, dealing with people with suicide, ideations, and other substance things. Really effective, and it's up kind of your way, up north somewhere. It's all up north, closer to you than me. But in looking after people, and they were just, totally shocked that the money was gone, and they just didn't know how they're going to replace some of that. So. There's a lot of decisions to be made, Madam Chair, and if you, the more help you want on some of those, I'm here, and we're interested, and you'll be telling us what you're thinking next week, I guess. But I just hope that we can preserve the good work of this thing, and at this point, it might be nation leading if there it is. But I hope that at the end, dust settles with this reorganization, and so I just pray it's all is well with these families. And Madam Chair, thank you.
Thank you. Members, any other comments or questions? I don't see any other. Thank you, Ms. Barnes, for the update. I really appreciate knowing more about, how your work is being affected. And, we do see this as a, real opportunity for our state to be able to continue work that helps so many families. And so it will be definitely a consideration. Senator Boldon.
Thank you, Madam Chair. I appreciate the opportunity to talk about this. Really, the work of the Rare Disease Advisory Council is critical and really, really impactful for many families across the state who are dealing with really difficult circumstances. And that is important always, but as we have talked about, in this moment, it is even more important. Minnesota really is a leader in this space, and we want to continue that and not move backwards. And given all the chaos and uncertainty that is happening at the federal level, it is all the more important that we are ensuring that this council can do this really important work. So thank you.
Yeah, thank you. And Senate File 2037 is laid over for possible inclusion. Thank you. Next on our agenda, we have Senate File 2530, Senator Hauschild. And Senate File 2530 has been heard in, several other places. And so the part of this bill that relates to our committee is Article 2, and that's the health article. Senator Hauschild.
Thank you, Madam Chair and members of the committee. Some of you may remember or have seen in the news that in northern Minnesota, in my district, we discovered the largest, when I say we, I mean, folks, not me, discovered the largest concentration of helium in the world. And so this is a really exciting prospect for us to once again provide the critical minerals that are needed for many of the technologies that we rely upon. And since we're in the Health and Human Services Committee, it's probably important for you to know that helium is utilized in MRI technology. In fact, 80% of helium's usage is for MRI technology. So it is critical to the medical technology field. It's a resource that's not just party balloons, it's used in rockets, in space exploration, like I said, medical technology, chip manufacturing, all the things that we all are going to rely upon. And Madam Chair, this is a substantially different type of mining, if you want to even call it that, from taconite or non-ferrous. It's a much cleaner process. It's a very, very small well in northern Minnesota. I'd love to have folks come up and visit it, but it's a very small site. And last year, we were able to pass an expedited rulemaking process, as well as a gas technical advisory committee, which looked into, throughout the interim, a update to the temporary framework that is necessary for us to extract this valuable resource. And so, Madam Chair and members, in this portion of the bill, I'll just sort of very quickly walk through the pieces that this deals with. It allows the recommendations for MDH include and require the program to have additional oversight over prospecting for gas, new authority to ensure exploratory gas borers are sealed properly, oversee development and oversight over gas wells, develop gas rules for new authority in Minnesota that currently do not exist, process gas wells construction and sealing, inspect and enforce gas well code, license gas well contractors, credential certified gas representatives, manage the report of work submitted to the commissioner to ensure exploratory boreholes and gas wells are sealed, and general fund appropriations to support development and staffing a gas well program. So, Madam Chair, as I mentioned, we do not have any framework for gas exploration in Minnesota. We've long done taconite mining, but we've never done gas, and so this is really meant to get us up to speed in that regard. And with that, I do have a testifier with Pulsar who can provide some more feedback and maybe answer questions, and then I believe the DNR and others from the GTAC advisory committee are here if there are questions.
Thank you, and welcome to the committee. If you can please state your name for the record and begin your testimony.
Thank you, Madam Chair. My name is Michael Sturdy. I am the General Manager of Operations for Pulsar Helium. So, good morning, Chair and Committee. I'd like to thank the state of Minnesota for considering legislation enabling helium exploration work to continue. For those not familiar with Pulsar Helium, Pulsar is a publicly traded company engaged in the exploration of primary helium. By primary helium, this means Pulsar is looking for helium as the primary commercial driver for our helium projects. It should be noted that most helium produced globally today is found as a serendipitous byproduct of hydrocarbon gas production. Pulsar's objective is to one day be the first helium producer that does not involve hydrocarbon extraction. And I believe that the state of Minnesota is the place where we can achieve that goal. As we found in Minnesota, the concentration of helium at the Topaz project in Lake County, Minnesota is approximately 10.5%. This is among the highest ever helium percentages measured globally and has the potential to be a world-class resource. And when helium is mentioned in conversation, most people gravitate towards party balloons. However, only 2 to 3% of all helium goes into party balloons. So what is it really used for? As the Senator mentioned, MRI machines is the biggest user of helium globally. It is a critical resource in our modern high-tech society and has no known substitutes for the technologies that require helium. And every MRI machine across the planet requires helium. The second largest user is the space industry. Every rocket that launches into space requires a significant amount of helium to safely lift off. Other industries requiring helium are chip manufacturers, which there are some here in Minnesota, fiber optics manufacturers, supercomputing, and many others. And I look forward to continue working with the Legislature, the Department of Natural Resources, the Department of Health, and the people of Minnesota to advance a regulatory framework that allows us for Pulsar to bring the first ever primary helium gas production project online and do it here in the state of Minnesota. I would be happy to answer any questions the committee may have.
Thank you very much for the presentation. Members, do you have questions or comments about the bill? Senator Lieske.
Thank you, Madam Chair. Senator Hauschild, I think this is a pretty important issue. Getting helium is going to be a very important subject. I guess my only question is MDH prepared to take over the licensing for this? I mean, I don't think this is something that's normally in MDH's wheelhouse, so I guess that's where I'm trying to figure out the drilling purposes, like the drilling licenses. This is kind of a different area for them.
Senator Hauschild, do you have a comment? I mean, they have an existing organization that deals with wells, borings, and that sort of thing. I don't know, Senator Hauschild, do you have more information you want to?
Yeah, thanks, Madam Chair, for pointing that out, and thanks, Senator Lieske, for the question. This would sort of put forward, the process by which they would be able to provide those license. I know that MDH has talked to me and throughout the GTAC process about what long-term could a gas framework really look like, and is it, I don't know, I hope I'm not getting ahead of myself here, but I mean, the possibility of sort of looking at who has jurisdiction over all of this and whether it's a new department or, under a certain agency, I think we're still sort of looking at that, but we're trying to sort of create the rulemaking process and the framework to sort of move in that direction. So I think those conversations are ongoing, but yes, this would give them sort of that ability to provide those licenses.
Senator Lieske.
Thank you, Madam Chair. Thank you, Senator Hauschild. I guess the only reason I'm asking is because we both sit on labor together, and that's kind of the realm that I would have expected to see the drilling specifically for this, falling under more of the labor market. So that's the only reason I was asking, is kind of just curious as to how MDH got into the discussion. Obviously, it's the purpose of what helium is going to be used for, maybe, but the commercial purposes of drilling, not necessarily something that MDH normally oversees. So that's why I was asking. And I think it's more of a Dolly thing than it is a MDH.
Senator Hauschild, I think I don't know, the GTAC, I know that the Department of Health was involved in that process, and I don't know if you can describe kind of what they went through, but I know that they were included in the discussions and the final report that came out, and at this point, we haven't heard that, these recommendations and what is in your bill is of concern to the Department of Health is something that they can take on, but I'm sure there are more discussions that are happening. And I don't know if that GTAC, can you tell me, is that something that's an ongoing entity that will continue to advise on this?
Thanks, Madam Chair, for the question, and thanks, Senator Lieske, for the follow-up. My understanding is GTAC was put into place to sort of put forward these recommendations. I think, and all those different, it's a multi-agency effort, and so there were folks involved in all that, and these are sort of what the agencies have put forward as the recommendations. I think they're always available for follow-up and for, doing what the legislator maybe dictates them to do, but at this point, they sort of are putting this framework forward and then going through the official rulemaking process to sort of make a lot of those official decisions.
Thank you. Any other questions? Members, Senator Mann.
Thank you, Madam Chair. Senator, I think you mentioned something about expedited rulemaking. Why did we go with expedited rulemaking instead of full rulemaking?
Senator Hauschild.
Sorry. Thanks, Madam Chair. Thanks, Senator Mann. We went with expedited rulemaking because this is something that was discovered very rapidly, and right now the drill is on private land, and so there was really sort of a need last year for us to put into place expedited rulemaking so that we have this process in place. There was fear that if we didn't put into place sort of this temporary framework, expedited rulemaking, that a lot of this gas could be sucked out of the ground and we wouldn't be sort of prepared to handle the situation. So that's kind of why we move forward quickly and are just trying to make sure we can manage this industry, as quickly as we can.
Senator Mann. Any other questions or comments? I see none. I don't have any other questions at this point. Senator Hauschild, any final comments?
No, I appreciate the dialogue on this. Like I said, it's really interesting to learn the more I do about helium and how important it is for things like medical technology. And I think the fact that Minnesota, will be able to provide this resource for our country and the world is another special thing about Minnesota and the district that I get to represent, where we provide a lot of the taconite, timber, critical minerals, and now gas that could be used for many of the technologies we use each and every day. So it makes me proud, and also I'm excited to continue moving this legislation forward so we can do it right.
Thank you, and I appreciate your testimony today, too. It was interesting to learn about. I was not aware that that was involved in MRI technology. So, members, this bill needs to move from our committee to taxes. So, Senator, let's see, is anybody on? Senator Kupek. Senator Kupek moves that Senate File 2530 be recommended to pass and be referred to the Committee on Taxes. Members, all those in favor, please signify by saying aye. Aye. Any opposed? The motion does prevail, and Senate File 2530 is passed and referred to the Committee on Taxes.
Thank you.
Thank you. And we have reached the end of our agenda, and we are adjourned.